What are the recommended medications or antiretroviral therapy that we should start immediately? Well, we have two guidelines in the United States. There's the DHHS, the Department of Health and Human Services, and then the International Antiviral Society. First, they both recommend rapid ART. And what is rapid ART? It is to start antiretroviral therapy as soon as possible after a diagnosis, potentially even same day. The IAS guidelines recommend Bic/Taf/FTC, which is co-formulated as Biktarvy, or dolutegravir, also known as Tivicay, with either Descovy, Taf/FTC, or Truvada, TDF/FTC. So those are the recommendations from IAS. DHHS also includes a protease inhibitor, darunavir. It needs to be boosted, and it comes co-formulated as Simtuza. I rarely use this regimen unless someone has been on cabotegravir for PrEP and they have had a breakthrough infection, or potentially they had an infection when there was a missed dose of the cabotegravir. So what are the benefits of rapid ART? Well, patients become virally suppressed more quickly. This isn't rocket science. If you start a medication sooner, you will get the effects sooner. And that's exactly what happens. A patient is virally suppressed usually 3 to 4 weeks later. But we also see in the data that people are more likely to have durable viral suppression. That's not because the medications are working. It's because the patient is more adherent to the medications when you start sooner. It can improve patient survival. We've seen this in international trials. We haven't seen this in the United States only because we have such great medical care if someone became sick. But we want to limit any comorbidities. It reduced the risk of age-related events. So those are those comorbidities. And it may improve longitudinal engagement in care. I have seen this over and over again in my clinic. And part of it is that relationship that develops between the provider and the patient. It also could improve equitable care. I really strongly believe in this. There are so many benefits of rapid ART, but I want to take a moment to recognize that this is a medical intervention that upholds equity. We have seen that due to inherent biases in the way we might practice or our health systems are developed, that patients are not provided equitable medical care. And I'll give you examples. Before a commitment to rapid start, Black men faced longer times until they were initiated on antiretroviral therapy. So they might have a first visit, then a second, then a third before they started. And the qualitative questions that came out of this study when asked why there was a delay was there was a higher presumption that that person was going to be non-adherent to the medications. So I really want to root out these ideas of non-adherence before even initiating therapy. And rapid ART is that commitment that we are treating everyone equally, that we are going to start medications as soon as possible after diagnosis. It could also reduce medical mistrust and reduce stigma. I'm saying to my patient at day one, this medication is so important. I would treat you like I'd treat myself, like I'd treat my family members. And we are now this team where I'm committed to ensuring your access to antiretroviral therapy. So can our antiretroviral therapy be started in the primary care setting? I strongly believe so. We've come such a long way in terms of our HIV medications. When you look decades ago, there was a lot of side effects, multiple medications, a real potential for liver and kidney injury. We are so far from that. Our medications now are often one pill once a day. Once someone's stable, they could even move to an injectable, which is every 2 months. So it's important to have a status neutral approach. We should be testing everyone for HIV. We all have a status. If that test is reactive, then we want to start ART as soon as possible. If that test is negative, we should be asking the question of our patients, how are you protecting yourself against HIV? And if it's clear that they might be in a monogamous relationship or they use condoms 100% of the time in their sexual activity, that might lead to a different conversation. But if they say, oh, I think about that often, but I'm not sure, how can I better prevent HIV? Well, then we must be discussing PrEP. PrEP is so incredibly effective at preventing HIV. These are the two pillars right now in how we end the HIV epidemic. Start ART immediately and keep people virally suppressed, and then have people on preventative medicine. And we're going to talk about U equals U, undetectable is untransmittable. But once someone is on antiretroviral therapy and virally suppressed, they cannot transmit the virus at all. And then on top of that, once on medications, it's impossible to transmit the virus. But the only way we can ensure that our patients have access is when we prescribe the medication and build an infrastructure in our clinics that's committed to this work. So I believe, just like hypertension, you can treat HIV. Actually, our medications are so well tolerated that we see that it is even, I see less side effects in my practice with my HIV medications than even treating hypertension. And that definitely goes the same way for diabetes. So HIV is something we should center within primary care. Rapid ART has few requirements. It can be initiated in the same way. We could protocolize this, and you should make sure that your providers, your PCPs are prepared to start rapid ART and PrEP. If we were all doing this, it would greatly reduce stigma. So do I need any labs to start treatment? Well, we've been having this conversation now for quite some time. Almost a decade ago, we started to lean into the idea that we don't need any labs. Our medications are so safe, so well tolerated, we could start them immediately. It took a little bit of time, but the DHHS and IES guidelines, as I've mentioned, now fully endorse rapid ART, and part of that is to start medications before you have labs, with the exception of HIV testing. So all you really need is HIV testing. You could start HIV medication same day for those patients. All you need is the HIV test confirming the diagnosis. Now you do though need labs on the day you start treatment, because you do need those labs to review. You just don't need them to initiate therapy. So what are they? Well, you would need to confirm the HIV test if not previously done. That's the only time you might wait until that confirmation is back to start antiretroviral therapy. But if you have that confirmation, then a viral load, which is the HIV viral load, the genotype, which shows you any resistance, a CD4 cells, as we know, HIV infects CD4 cells and brings those levels of CD4 cells down. So it's important to have that baseline. You need hepatitis B testing, hepatitis C testing. Of course, you're going to get a comprehensive metabolic panel. You're going to get a CBC. I always add a lipid profile, a urine analysis, and a pregnancy test. But now I'm going to focus on what also needs to be included, and that's your STI testing. For me, a real commitment to 3-site testing: gonorrhea, chlamydia testing in the throat, rectum, and urine. I always tell my patients I'm going to do a full 3-site panel at initiation of care, and then as we get to know each other, I could determine what testing you may need in the future. Syphilis testing, and for women, trichomonas testing. So I add all of that to my labs. I often get the question, how about a CD4 count? Are we basing treatment on CD4 count? Well, many of you might have been trained in a time when we did base treatment on CD4 count. That is now gone. Every guideline actually in the world now recommends, the World Health Organization, all the European guidelines, and of course our 2 guidelines in the United States recommend starting ART regardless of CD4 count. You also start it regardless of viral load. As soon as someone is diagnosed with HIV, and if they're not on medication, they will have a viral load, an HIV viral load, so you're starting that medicine. They can be started because these medications are so incredibly safe. The other question I often get is, how about resistance? Are you worried about these medications not working? And the answer is no, I'm actually not. We have very, very rare integrase transmitted resistance. So those two medications that's recommended by IAS, the Biktarvy, which is bictegravir, TAF, FTC, or dolutegravir, known as Tivicay, with either Truvada or Descovy, can be used as first line without any concern. And really, we don't see impact on renal and hepatic function. You'll monitor it, and you of course need to know at baseline what a patient's renal or hepatic function is, but they're so incredibly safe. And I also want to point out both of the recommended regimens cover hepatitis B.